Hi, my name is Amy Vibert. This is my Integrative Review presentation for NSC 890. My review is on the overuse of antibiotics in respiratory tract infections. My study was guided by my PICO question initially, which states, in patients with a diagnosis of acute respiratory infection, how does the shared decision-making model affect the patient's decision about antibiotic use compared to a patient who is not offered the shared decision-making model, affect the reduction of antibiotic use and overall patient outcomes following treatment within a 2-week period? With this question, I was able to look up articles and find articles that had interventions pertaining to decreasing the overuse of antibiotics for respiratory tract infections. This is a problem, antibiotic overprescribing. Despite campaigns, monitoring of antibiotic use, and general awareness, there seems to be little improvement to decreasing the amount of antibiotics that are prescribed unnecessarily. Prescribing unnecessary antibiotics contributes to antibiotic-resistant bacteria, potential medication side effects, and then overall increased costs for patients. Respiratory tract infections are the most common reason that people consult a primary care physician. That accounts for over 75% of antibiotics that are prescribed. The studies that I found were, the 3 studies that I reviewed were randomized controlled trials. They each had different interventions, but they all had benefits to those interventions. Study 1 was based on the shared decision-making model, where the patient was informed about the risks and benefits of taking the antibiotic and they chose to take the antibiotic or not. With this study, there was a 16% reduction in the amount of immediate antibiotic use. The second study was using a point-of-care C-reactive protein test at the bedside to evaluate whether patients could benefit from or if the antibiotic was necessary. There was a 2% reduction in the amount of antibiotics that were prescribed with this study. Study 3 was also a randomized controlled trial, and it used education, auditing, and feedback of the prescriber to determine whether or not an antibiotic should be prescribed and what antibiotic to prescribe. With the third study, at 1 year, there was a 16% reduction in the amount of antibiotics prescribed, and at 2 years, there was a 2% reduction. So as you can see, all 3 studies had somewhat of a reduction that was noted. This affects nurse practitioners because we want to give quality care. We don't want to prescribe medications that aren't necessary. Advanced practice nurses have the opportunity to improve practice by decreasing the number of unnecessary antibiotics that are prescribed for respiratory tract infections specifically. So an easy intervention, I feel like, would be the C-reactive protein point of care that could be implemented into either primary care or an urgent care facility. This intervention specifically is cut and dry. There are specific guidelines that are laid out. For instance, in this particular study, if your C-reactive protein level was less than 20 milligrams per ml, you would not be prescribed an antibiotic. If your C-reactive protein was greater than 100, you would be prescribed an immediate antibiotic. And if your CRP fell between the levels of 20 to 99, your antibiotic would be delayed. This intervention would be easy to implement, easy to educate patients on. You would get fast results, immediate results. You wouldn't have to wait for the lab tests to come back or be sent off. They would be done at the bedside. And it can decrease the amount of antibiotics that are prescribed unnecessarily. So that is the results of the integrative review that I've done for this project. Thanks for listening. Bye.